Understanding the distinction between complete and incomplete right bundle branch block is essential for accurate ECG analysis. While they share a common look, the difference lies entirely in the speed of conduction through the right ventricle. The key diagnostic differentiator is QRS duration. The primary way to distinguish between the two is the measurement of the QRS duration. Both patterns involve a delay in right ventricular depolarization, but the extent of that delay defines the category. QRS duration is between 100 and 120 milliseconds in incomplete right bundle branch block, while it is 120 or more milliseconds in complete RBBB. V1 morphology is similar. RSR prime of various types can be seen in either incomplete or complete RBBB. Lead 1 and V6, the shallow slurred S wave is seen in incomplete RBBB, while it is a bit deeper, wider and more slurred S wave in complete RBBB. Morphological similarities are there in both cases. You will see the classic rabbit ears in the right precordial leads V1, V2. This happens because the left ventricle depolarizes first, that is the tiny R wave, followed by a delayed signal traveling to the right ventricle, that is the bigger R wave. The right bundle branch is a long, thin and fragile part of the conduction system. In complete RBBB, the electrical impulse is entirely blocked in the right bundle branch block. The right ventricle must wait for the impulse to travel through the left bundle and then seep through the myocardium, muscle-to-muscle conduction. This is a slow process, hence the QRS width of 120 milliseconds or more. In incomplete RBBB, the right bundle branch is not completely blocked but conducts more slowly than usual, or there is mild right ventricular hypertrophy causing a slight delay. The signal eventually gets through the conduction system, but it takes just a bit longer than the standard 100 milliseconds. Coming to clinical significance, the implications of these findings vary significantly based on the patient's presentation. Incomplete RBBB may be seen as normal variant in healthy asymptomatic individuals, especially athletes with no underlying heart disease. But it could be due to right ventricular strain, can be a sign of early or mild right ventricular hypertrophy, often seen in conditions like atrial septal defect. It rarely progresses to a complete heart block on its own. On the other hand, complete RBBB is more frequently associated with structural heart disease such as coronary artery disease, hypertensive heart disease, or pulmonary embolism, that is acute onset. Unlike left bundle branch block, a complete RBBB does not usually hide an acute myocardial infarction on an ECG, as the initial phase of the QRS, that is septal depolarization, remains intact. New onset RBBB is a common occurrence following certain cardiac surgeries. To summarize, when you see an RSR prime pattern in V1, check the QRS width. Is it less than 120 milliseconds? Then it is incomplete RBBB. If it is 120 milliseconds or more, it is complete RBBB. Check the S wave. Is there a slurred S in lead 1 or V6 that is seen in RBBB? Check the axis. Is there a concomitant axis deviation? Then consider bifascicular block. If it is left axis deviation, there is associated left anterior hemiblock. If it is right axis deviation, it is associated left posterior hemiblock.